I want you to imagine, just for a moment, that the year is 2030. You are dropping off your child or maybe sibling at the local hospital for a completely routine appendectomy.
Right.
It is the kind of procedure we have, taken for granted for decades. You go in, they make a small incision, remove the appendix, and you are usually home the next day.
Usually, yeah.
But in this reality, in 2030, you are terrified. You are gripped by the kind of fear people used to have before they even invented penicillin.
Because the environment itself has become the threat.
Exactly. You are terrified because the post-antibiotic era has officially arrived. The surgery itself goes perfectly. I mean, the surgeon is skilled. But the hospital environment, the air vents, the bed rails, the chairs in the waiting room, they are just teeming with microscopic, multi-drug-resistant pathogens.
It is a nightmare scenario.
It really is. The simple act of opening the human body has become a lethal gamble, and in this incredibly bleak near future, common surgeries are now a leading cause of death due to antimicrobial resistance, or AMR.
It is a profoundly chilling image. And I think the most unsettling part of looking through our stack of research today is realizing that this scenario is not science fiction.
Not at all.
No, it is the exact trajectory we are currently on. We are looking at a mathematical certainty if the global community does not drastically alter its approach to public health and infection control. We are genuinely standing on the precipice of a medical regression. It could undo over a century of modern medical progress.
Well, welcome to the deep dive. We have an absolutely massive and frankly eye-opening stack of source materials to get through today.
You really do.
Yeah. We're pulling from official policy documents from the World Health Organization. We have these critical, completely unfiltered excerpts from the writings of Dr. Karyali Srivatsa.
Yes, specifically looking at his books like The Pandemic Survival Guide and The Art of Self-Diagnosis.
Right. And we are also wading through dense academic research papers on infection control, focusing on how pathogens behave in confined spaces. And finally, we have our hands on a detailed business and policy plan for a radical piece of hardware and software called the Prima Kiosk.
Powered by Dr. Maya AI.
Right. So it is a really diverse array of sources today.
Spanning public policy, microbiology, artificial intelligence. But, they all converge on a singular, highly critical perspective.
Right, which brings us to our mission today. We need to unpack a very uncomfortable argument presented across the board here. The argument that doctors, politicians, and global health decision makers have fundamentally failed us when it comes to the early detection of infectious diseases and this looming threat of AMR.
It is a heavy accusation.
It is. Okay, let's unpack this, because the sources really do not hold back at all. They argue that our current methods of testing, diagnosing, and quarantining are not just outdated.
No, they are an active financial black hole.
Yeah. A black hole that is actively accelerating the spread of disease. And the proposed escape route from this nightmare isn't a new, billion-dollar super hospital with shinier floors.
No, it is a decentralized, solar-powered AI kiosk sitting on a street corner.
Run by a local vendor. I mean, it is wild.
That represents a massive paradigm shift. We've spent decades, arguably centuries, building these massive centralized cathedrals of medicine. We funnel all our resources into these centralized hubs.
Right.
So to suggest that the survival of our species relies on dismantling that monopoly and distributing that diagnostic power down to the grassroots level, well, it requires us to first deeply understand the catastrophic missteps that got us to this breaking point.
So where do we start?
The sources suggest that the very institutions designed to protect us, places like the WHO and the CDC, are operating on a kind of theoretical idealism. And it is completely detached from the physical reality of how pathogens actually move through a population.
Okay, let's dive right into that physical reality. Because the sources point out a glaring flaw in our standard operating procedure during any outbreak. They call it the travel to test paradox.
Yes, this is crucial.
I want to look at what actually happens when a new virus or resistant bacteria emerges. The very first thing public health officials broadcast is, if you have symptoms, go to a testing center. Go to your doctor.
Go to the hospital to get a swab or a blood test.
Right. And, the more I read this, the more I started picturing it like a compromised firewall on a computer network.
Oh, that is a great way to think about it.
Yeah, like if you have a virus on one computer in your office, your IT department doesn't tell you to carry that infected hard drive through the entire building.
Just plugging it into every server along the way.
Exactly, just to get to the IT desk so they can run a diagnostic on it. You isolate the machine immediately. But with human beings, We tell the infected person to walk through the entire network.
That firewall analogy captures the mechanical failure perfectly. The clinical reality emphasized in Dr. Sravats's writings is that laboratory tests and complex investigations should only ever be used to confirm a diagnosis that a clinician has already suspected.
Based on symptoms.
Right, based on symptoms, they should never be the initial gateway to care. The reliance on the test creates a dangerous lag time because tests are never 100% accurate anyway.
Right, false negatives are super common early on.
Exactly. But more importantly, the physical act of moving a symptomatic patient out of their home turns them into an active moving vector.
Let's trace that patient's journey, just to visualize it. They wake up with a fever and a cough. They are told to go get tested, so they leave their house, they touch the door handle of their apartment building.
They get on a public bus.
Or the subway, yeah. Breathing into a shared, poorly ventilated space for 20 minutes. Then they walk into a clinic or a hospital, they interact with a receptionist, and then they sit in a waiting room, sometimes for hours.
Surrounded by other people. And at every single stage of that journey, they are shedding spores, viruses, or bacteria. They are exposing entirely healthy populations, or even worse, vulnerable populations who are already in the hospital for other reasons.
And all of this massive exposure risk is undertaken just to obtain a piece of paper. A piece of paper that confirms what the patient's symptoms already strongly suggested, that they are sick and contagious.
The text actually goes as far as calling this protocol unethical.
Unethical, wow.
Yes. You are asking a sick person to spread their infection, yes, but you are also actively endangering them. Think about that hospital waiting room. It is quite literally the last place a sick person should be.
Why is that? Because of their immune system.
Exactly. If you go in with a relatively mild viral infection, your immune system is already distracted. It's busy fighting that virus.
Yeah.
While you sit in that waiting room chair waiting for your name to be called, you are exposed to a concentrated soup of resistant bacterial or fungal pathogens.
Shed by the other patients.
Right. You go in with a bad cold and you leave harboring a superbug.
That is terrifying.
And this specific vulnerability brings us to the severe critique of how quarantines and lockdowns have been managed historically.
Oh, right, the lockdowns.
The traditional public health model, which we saw heavily utilized in recent global pandemics, involves contact tracing followed by quarantining individuals. But the critical failure highlighted in the sources is the practice of mixing healthy adults, children, and infected patients in the same centralized facilities or hospitals.
The authors describe mass lockdowns as a knee-jerk reaction, which, makes sense when you look at it this way. It disrupted the global economy, it caused immense psychological harm, but fundamentally it failed to address the root cause of transmission.
Which is early, isolated home care. By mixing the healthy and the infected in these confined, pressurized spaces like hospital wards, the pathogen simply found a denser, target-rich environment.
So they basically locked the fox in the henhouse.
Exactly. And the clinical outcomes of this mixing are devastating. Yeah. The sources point to the alarming rates of secondary infections acquired specifically within hospital settings. When a patient with a viral infection is exposed to a multi-drug-resistant bacteria in a hospital, it often leads to sepsis.
And sepsis is, let's define sepsis for the listener really quickly.
Sure, sepsis isn't just an infection. It's a dysregulated immune response, where the body essentially starts attacking its own organs to fight the invader. It leads to multi-organ failure.
Oh, wow.
And the mortality statistic provided in the text is grim. Multi-organ failure resulting from sepsis in these scenarios kills 9 out of 10 people admitted.
9 out of 10. I mean, that is an almost insurmountable mortality rate once it reaches that stage.
It forces us to view the hospital environment through a totally different lens. We have a research paper in our stack from Anaja National University that specifically investigated the radiology department as a potential reservoir for multi-drug-resistant microorganisms.
Wait, radiology? You mean where they do x-rays and MRIs?
Yes.
I always tend to think of those areas as like super clean, high-tech environments.
Most people do. But the paper found that even these diagnostic areas are hotbeds for contamination. The equipment is difficult to fully sterilize between every single use. The airflow systems can circulate pathogens, and patients are constantly moving in and out.
That makes a lot of sense.
The paper heavily emphasizes the need for early detection outside the hospital. specifically to limit the movement of undiagnosed patients, because these resistant bugs linger on surfaces for days or weeks.
Which makes the historical track record of our global health institutions so incredibly frustrating to read about in these sources.
It really is.
Because the authors don't just blame the methodology of centralized testing, they point directly at the historical blind spots, the bureaucratic delays, and the political maneuvering of organizations like the World Health Organization and the CDC.
They argue there is an undeniable pattern of catastrophic delay that has cost millions of lives. The historical examples cited in the text are meant to illustrate a structural inability to respond to fast-moving biological threats.
Like the 2002 SARS outbreak.
Exactly. They look back at SARS. The sources argue that Chinese leaders suppressed information and hid the presence of the virus for crucial months, primarily out of concern for the economic impact on trade and tourism.
Right. And a centralized global health body is entirely dependent on the honesty and speed of its member nations. If a nation hides the data, the global body is completely blind.
Blind and paralyzed. And it isn't just one isolated incident. They point to the 2004 avian influenza outbreak in Thailand, where officials exhibited a similar reluctance to release timely information.
Again, allowing the pathogen to gain a significant foothold before international protocols could even be triggered.
Right. But the critique becomes particularly severe when examining the World Health Organization's response to the Ebola outbreak in West Africa.
Yeah, this part was staggering to read.
The text points out that it took the WHO months to even officially recognize that an Ebola outbreak was occurring.
Months.
That bureaucratic delay in declaring an emergency and mobilizing resources resulted in over 28,000 deaths.
Over 28,000 deaths.
Oh my God.
The authors argue that if local communities had the tools to identify the hemorrhagic fever symptoms immediately, rather than waiting for Geneva to process the paperwork and confirm lab results, a massive portion of those deaths could have been prevented.
I think it's really worth noting here because Dr. Srivats's text really doesn't hold back politically. He actually points to the previous U.S. administration, specifically Donald Trump's decision to withdraw U.S. funding from the WHO as a correct structural move.
Yes, he does.
And I want to pause here for a second. Regardless of where you, the listener, fall in the political spectrum, we have to state that we are impartially reporting the source author's perspective here without taking any political sides.
Absolutely.
But the core argument the author is making isn't really about partisanship anyway. It is about the speed of bureaucracy. He's arguing that the WHO has just become this massive, slow-moving apparatus.
The phrase used in the text is striking. It describes the WHO as a white elephant staffed by academicians.
A white elephant staffed by academicians.
The implication is that the people writing the protocols are theoretical researchers far removed from the dirt, the chaos, and the speed of a clinical front line.
They operate on models that assume perfect data sharing.
Perfect compliance, unlimited resources, which simply does not reflect the reality of fighting a disease in a crowded, under-resourced environment. Centralized global governance in health lacks binding authority to force nations to report accurately. It suffers from severe communication lag, and it simply cannot move as fast as a mutating virus.
And perhaps the only thing matching the physical damage of this delayed, centralized response is the staggering financial waste it generates.
A little financial black hole.
Yes. The sources paint a picture of a system that is not only failing to stop diseases, but is literally burning billions of dollars in the process. We know that bringing people to hospitals for testing is dangerous, but how do public health departments currently try to prevent those outbreaks in the first place?
They spend absolute fortunes on mass education campaigns.
Right. This is a critical area of analysis in the text. Public health departments globally rely heavily on mass media. We're talking about television advertisements, billboards, highly designed printed posters, and complex written notices distributed to clinics.
These materials focus on hygiene practices like hand washing, symptom checking, and social distancing.
And I am looking at this argument, and part of me thinks, okay, maybe it's inefficient, but shutting down public service announcements entirely feels reckless. Surely some information is better than no information, right?
You would think so.
Yeah.
But the text hits on a massive blind spot that completely undermines the value of these campaigns, the illiteracy disconnect.
Right.
What's fascinating here is the disconnect is profound. The sources highlight a fundamental demographic reality. The populations most acutely at risk during an outbreak, poor street vendors, subsistence farmers, domestic workers, marginalized migrant communities living in high-density areas, they're often predominantly illiterate.
Or, even if they possess basic literacy, They simply cannot comprehend the complex, sanitized medical jargon drafted by academic health officials.
Exactly. The author provides such a stark contrast. Picture a highly educated public health official sitting in an office in Geneva, carefully drafting a protocol about asymptomatic transmission and respiratory droplets.
And they spend thousands of dollars designing a poster with this information.
Right. And on the receiving end, the target audience is a Bengali mother working multiple jobs in East London or a rural farmer in Bihar, India. The sources argue that these mass communication campaigns generate absolutely no ROI.
No return on investment.
None. You are pouring millions of dollars of public funds into propaganda that the target audience literally cannot decode.
It's just noise to them.
Healthcare inequality is frequently framed purely as a matter of financial resources, like who can afford the medication. But the sources argue that inequality is fundamentally about access and comprehension. If a community cannot understand the warning signs of an outbreak because the warning is written in a bureaucratic language they do not speak, they cannot alter their behavior.
The information is useless.
Completely useless.
And the financial burden of this completely ineffective communication is then heavily compounded by the economic burden of the medical response that inevitably follows. Because people don't understand the early symptoms, because they couldn't read the poster, they don't isolate.
They go to work.
They wait until they are severely, undeniably ill. Only then do they enter the centralized medical system.
And by the time they enter the system, the cost of care has skyrocketed. It requires ambulance infrastructure to transport them. It requires emergency room triage. It requires the random broad testing panels we discussed earlier, which are expensive and slow.
And here is where the medical and financial crises sort of merge. Because the doctors in the ER don't know exactly what pathogen they're dealing with while they wait hours or days for test results. They are forced to treat the patient empirically.
Yes.
So let's define empirical treatment for the listener really quick. That essentially means the doctor is making an educated guess based on the severe symptoms, right? They just throw a broad-spectrum antibiotic at the patient and hope it kills whatever is making them sick.
That is exactly what it means. It is a shotgun approach. Broad-spectrum antibiotics are designed to wipe out a wide variety of bacteria. It is incredibly expensive to use these high-end drugs as a first line of defense, but more importantly, it is medically disastrous in the long term.
Because it is the primary driver of antimicrobial resistance.
Yes, you are carpet bombing the patient's microbiome, killing the good bacteria, and allowing the strongest, most resistant bugs to survive and multiply.
Right. But I'm still struggling with one aspect of this critique. Even taking all of this into account, the slow bureaucracy, the unreadable posters, the broad-spectrum antibiotics, isn't funding public health infrastructure still a net positive? I mean, even a flawed hospital system seems better than leaving people to fend for themselves. Why are the sources so vehemently opposed to continuing to fund this centralized model?
Well, the sources introduce a deeply cynical but heavily documented counter-argument by examining the privatization and corporatization of healthcare.
Okay.
They look specifically at environments like India, though the model applies globally. The text points out that many major hospitals and diagnostic centers are entirely for-profit entities. In many cases, they are owned and managed by the very doctors who practice in them, or increasingly, by massive corporate conglomerates.
And how does that affect the tracking of an outbreak?
According to the sources, these institutions have a massive financial disincentive to share infection data with public health authorities.
Wait, really?
Yes. Think about it. If a private, for-profit hospital admits that they have an outbreak of a multi-drug resistant superbug in their ICU, their reputation plummets. Patients will cancel elective surgeries, which are the primary revenue drivers.
Oh, wow.
Therefore, the text claims, these hospitals categorically decline to accept they have an outbreak problem. They actively hide the data to protect their bottom line.
That is horrifying. So the public health officials are flying blind because the data they need to track the spread is being suppressed just to keep stock prices high or to keep the VIP suites booked.
Furthermore, the sources point to a document titled The American Healthcare Nightmare Has Arrived in India, which details the aggressive takeover of healthcare systems by private equity firms.
Private equity.
When private equity enters the picture, the focus shifts entirely to margin optimization and revenue extraction. Doctors are placed under intense pressure to meet procedure quotas and prescribe expensive, unnecessary diagnostic tests.
So in that environment, a patient walking through the doors isn't viewed as a public health vulnerability to be isolated. They are a revenue stream to be extracted.
Exactly. Treating an uneducated patient empirically with expensive diagnostic panels and high-margin broad-spectrum antibiotics drains community resources and insurance pools. And because the true nature of their infection is often hidden from the National Registry, this extraction of wealth does absolutely nothing to cure the underlying, undocumented spread of the disease within the broader community.
So the public health expenditure on top of this private extraction is rendered completely useless.
Useless.
It is a terrifying intersection. We have bureaucratic inefficiency at the WHO level, unchecked capitalism at the hospital level, and ineffective communication at the street level. And the cumulative result of all these failures, the delays, the unnecessary travel of sick patients, the hidden corporate data, the carpet bombing with broad-spectrum antibiotics, is the creation of the ultimate biological nightmare.
It perfectly sets the stage for the reality of 2030 that we discussed at the beginning of the show.
Right. We are facing the silent tsunami of antimicrobial resistance.
The post-antibiotic era is not an abstract concept in these sources. It is a meticulously documented, impending reality.
Yeah.
The data shows that the pathogens are evolving much faster than our regulatory frameworks or our pharmaceutical pipelines can handle.
The sources describe a phenomenon that sounds like it was pulled straight from a sci-fi horror film. They detail a deadly artificial alliance between antibiotic-resistant bacteria and aggressive fungi.
Yes.
And the text is incredibly clear that this is not some random act of natural evolution. This is an artificial disaster fueled entirely by human behavior.
We really need to unpack the mechanics of this alliance because it is fascinating and terrifying.
Yeah.
We have essentially run a century-long, uncontrolled experiment in training microbes to survive our best weapons.
Right.
The sources list the primary drivers. First, the massive overprescription of antibiotics. We saw this peak dramatically during the COVID-19 pandemic.
Oh, yeah. Doctors were dealing with a novel viral pneumonia, and antibiotics do absolutely nothing against a virus. But because doctors were terrified and patients were demanding treatment, they prescribed heavy antibiotics just in case there was a secondary bacterial infection.
They prescribed them without confirmed bacterial cultures. But the environmental drivers are just as severe. The sources point to global industrial pollution, rampant open defecation in developing nations, which introduces immense amounts of human pathogens into the environment, and the highly dangerous practice of dumping toxic hospital and pharmaceutical waste directly into water sources.
That's just a recipe for disaster.
And we are also consuming food products from agriculture that relies heavily on chemical antimicrobial agents to keep livestock alive in terrible conditions.
So we are basically continuously bathing our environment in low-level antimicrobials.
Precisely. We are creating the perfect evolutionary crucible. Only the strongest, most adaptable microbes survive this constant chemical assault. And what scientists are observing, which the sources highlight, is that these superbugs are forming symbiotic relationships. Fungi and bacteria are actually teaming up.
Wait, how does that actually work? How does a fungus team up with a bacterium?
Well, fungi are incredibly structurally resilient. Some fungi can create thick, sticky, extracellular matrices, essentially building a physical reinforced bunker called a biofilm.
Okay.
Bacteria, which might otherwise be vulnerable to our antibiotics, can harbor inside this fungal biofilm. The fungus provides the physical shield against the medication, and in return, the bacteria might produce enzymes that help the fungus metabolize nutrients or fight off other competitors.
Wow, they are sharing survival traits.
Yes. When you have a combined fungal bacterial infection shielded by a biofilm, standard antibiotics simply bounce off.
And the numbers the sources provide regarding the casualty rate of these shielded superbugs are apocalyptic. I mean, if we continue on this path without a radical intervention, the projections state there will be 16 million deaths annually by the year 2050. Due strictly to drug-resistant infections. Just to visualize that for you, listening, 16 million people is more than the entire population of Tokyo, wiped out every single year, strictly from infections like staph or strep that we used to cure with a cheap pill.
It's hard to even comprehend.
And in India alone, the sources cite 500,000 annual deaths occurring right now and project an economic burden of 3 lakh crore rupees by 2030 just trying to manage these untreatable patients.
It is a level of sustained annual casualty that would cripple global healthcare infrastructure and devastate the global workforce. And the reason those numbers are so high is because of the profound medical void we are currently facing.
Right.
We have a very dense, illuminating research paper in our stack, authored by Dr. Kudapatha Menatha Jayasri, published in the International Journal of Pharmaceutical Sciences. This paper exhaustively details the current state of vaccines and biologic strategies aimed at these emerging resistant infections.
I read through that paper hoping for a silver bullet. We always sort of assume that when things get bad enough, the pharmaceutical companies will just invent a new class of drugs or a new vaccine in the nick of time. What is Dr. Jaisri's actual verdict?
The verdict is highly concerning for anyone relying on a pharmaceutical rescue. Dr. Jaisri's research indicates that while there are novel and evolving strategies being researched, she specifically discusses things like oral immunostimulants, which try to broadly boost the body's innate immune response, or targeted parenteral vaccines.
Let's clarify that term for a second. Parenteral vaccines just means vaccines administered via injection or infusion, bypassing the digestive system, correct?
Correct, as opposed to an oral drop. The research is exploring these injected vaccines targeting specific resistant strains. But the critical takeaway from the paper is that these biological strategies are still largely in the experimental or early clinical stages.
So they aren't ready to be mass-produced.
Far from it. Developing a new vaccine or a novel biologic agent requires massive, multi-year randomized controlled trials. You have to establish absolute efficacy against a mutating target, determine exact dosages for different age groups, and rigorously prove long-term safety to avoid autoimmune side effects.
Right.
This process takes years and often decades of sustained funding and research.
And the pathogens are mutating faster than the trial phases can be completed.
Exactly. Furthermore, we face a massive diagnostic bottleneck. We simply do not have rapid tests that can identify the millions of continuously evolving bacterial and fungal strains in a standard clinical setting.
We don't have the tools.
Right. The high-end mass spectrometry and genetic sequencing technology required to identify a specific mutated superbug exists in advanced laboratories, sure, but it takes days to get a result. And it is absolutely not available at the point of care for the billions of people in rural clinics or crowded urban centers who need it immediately.
So to summarize the bleakness of this void, we lack the rapid diagnostic test to figure out exactly what mutated superbug is killing the patient in front of us. And even if we miraculously knew the exact genetic sequence of the bug, we lack the novel antibiotics, the specific vaccines, or the biologics to actually treat them. We are flying blind and shooting blank.
Which is why the conclusion drawn by the authors of these sources is absolute, and why they reject the current public health model so aggressively. Because we cannot rely on a pharmaceutical miracle to save us from AMR, the only mathematically viable option left for the survival of our species is early detection based purely on clinical symptoms, followed by immediate, strict isolation at home.
Right.
We have to break the physical chain of transmission before the infected patient ever steps foot outside their door and reaches the hospital.
Which, sounds completely logical in theory, but feels utterly impossible in practice. How do you implement early, accurate detection and enforce immediate isolation for billions of people?
It's the ultimate challenge.
Especially when we've already established that a massive portion of the most vulnerable populations are illiterate, living in areas with no reliable access to doctors, and are terrified of losing a day's wages if they stay home based on a mild cough. The centralized WHO system has failed them. The complex propaganda posters have failed them.
And this is exactly where the narrative of our sources makes a sharp, dramatic pivot. It shifts from diagnosing the catastrophic failures of the current system to presenting a highly specific, radical, and technologically driven solution.
Okay, here we go.
The sources argue that we must bypass the bureaucratic inertia and the massive hospital monopolies entirely. We have to implement decentralized grassroots technology that operates at the neighborhood level.
We are talking about the Prima kiosk and Dr. Maya AI. Okay, let's really paint a vivid picture of what this technology actually is, because when I first read AI kiosk, I sort of pictured an iPad bolted to a wall running a basic WebMD search.
I think a lot of people picture that.
But this is significantly more advanced. PRIMA is an acronym. It stands for Personal, Responsive, Empowering Medical Assistance.
Visually, you can think of the Prima kiosk as the modern, intelligent successor to the public telephone booth, or perhaps a ruggedized ATM, but dedicated entirely to frontline healthcare triage. It is a standalone, physical terminal designed to be placed directly into communities. Crucially, the business plan dictates that it is solar-powered or battery-operated.
That is a massive detail. It means it does not rely on a stable national electrical grid, which is a major hurdle in developing nations or during natural disasters. You can drop this kiosk in a remote rural village in Karnataka, India, place it in a crowded underground metro station in Delhi, or install it in an underserved low-income housing estate in the UK, and it will function independently.
It is designed for absolute accessibility. It is completely touch-free, utilizing motion sensors and voice recognition, or it can use a simple, durable touchscreen interface that is sanitized by UV light. But the physical hardware is just the delivery mechanism. The real paradigm shift is the software running inside it, Dr. Maya GPT. This is an artificial clinical intelligence system built on the foundation of 50 years of direct medical practice by Dr. Srivatsa.
How does Dr. Maya GPT actually think? How is it different from someone just, typing their symptoms into a search engine?
A standard web search uses keyword matching to pull up articles, which often leads a patient to assume the worst. A simple headache becomes a brain tumor in 3 clicks.
Right. All been there.
Dr. Maya GPT, according to the documentation, is designed to replicate the differential diagnostic reasoning of an experienced junior doctor at the point of first contact. It uses branching logic. If you say you have a cough, it doesn't just list diseases that cause a cough.
Yeah.
It asks about the nature of the cough. Is it dry or productive? What color is the sputum? Do you have a fever? Have you traveled recently?
Wow.
It weighs the statistical probability of different pathogens based on current local epidemiological data.
And it completely overcomes the illiteracy barrier we spent so much time discussing. The kiosk uses audio-visual prompts in over 30 different languages and local dialects.
Yes.
The business plan provides a great hypothetical example: an 85-year-old grandmother who cannot read and has never used a smartphone in her life. She can walk up to this kiosk on her street corner and converse with it in her native dialect. The AI patiently guides her using images and voice prompts. It asks, "Do you have an open wound? Is there an abscess? Are you feeling breathless?"
The diagnostic capability is further enhanced by its ability to integrate with IoT, or the Internet of Things, peripheral devices. The kiosk isn't just asking questions, it can take physical measurements.
Like what?
It is equipped to take blood pressure, record blood oxygen levels using a pulse oximeter, and the blueprints show integration for performing spirometry.
Let's explain spirometry quickly for the listener.
Spirometry is a common pulmonary test that measures lung function, specifically the volume and speed of air a patient can inhale and exhale. It's crucial for identifying respiratory distress early. The kiosk can also guide the user to perform self-swabs for specific rapid antigen tests, and future iterations include basic ultrasound capabilities right there on the street corner.
Here's where it gets really interesting. Once the AI has gathered the patient's symptoms, analyzed their vital signs, and run its differential diagnosis, it doesn't spit out a dense 3-page medical report full of Latin terms that the patient cannot understand.
Right.
It translates that complex clinical data into a proprietary color-coded triage system. It is brilliantly simple, relying on universal visual cues. Or red means it is a critical, life-threatening emergency, and the kiosk can automatically connect the patient to an ambulance service. Green means the symptoms are mild, perhaps a common cold or a minor scrape, and the kiosk provides instructions on how to manage it at home with basic over-the-counter care.
The green code alone represents a massive, immediate cost saver for global health systems. It prevents panic-driven emergency room visits for minor ailments, which currently clog up triage queues and exhaust hospital resources. But the critical innovation, the feature explicitly designed to halt the AMR tsunami we discussed, is the BLUE code.
The blue code. The sources literally refer to this specific code as the pandemic breaker.
When the kiosk screen turns blue, the AI has determined that there is a high infection risk. It has flagged the patient's symptoms as indicative of a highly contagious state or a bacterial infection that may require antibiotics. And here is the revolutionary decentralized intervention. The kiosk tags the patient for home quarantine immediately.
It speaks to them in their own language and says, "You are a potential vector. You are highly contagious. You must return home immediately to protect your family and your village."
It doesn't just abandon them with a warning, though. It connects them via an integrated telemedicine link to a validated human doctor who can quickly review the AI's findings, issue a necessary prescription, or provide specific advice. But the vital mechanical function is that it stops the patient from physically traveling to a centralized clinic.
Going back to our earlier analogy, it catches the infected computer before it plugs into the main server network. It stops the person from sitting on the bus, touching the door handles, and coughing in the hospital waiting room.
If we connect this to the bigger picture, let me add another layer to that, grounding it in the academic literature from our sources. We have a conference research paper titled "Infection in a Confined Space," using an agent-based model.
What exactly is an agent-based model?
It is a type of computational modeling used heavily in epidemiology. Think of it like a highly advanced simulation game. like the Sims. You program individual agents, representing people with specific behaviors, and you place them in a simulated physical environment, like a hospital ward. The model tracks how these agents interact, how air flows, and how a pathogen spreads from person to person over time.
Oh, fascinating.
This specific paper uses an agent-based model to mathematically prove how rapidly pathogens disseminate in environments where sick people congregate and wait.
So the math proves that the waiting room itself is the superspreader event.
Precisely. And by keeping the bleak-coated patients at home, the Prima kiosk directly mitigates the catastrophic risks outlined in this computational literature.
Yeah.
You are eliminating the hospital waiting room as a vector for secondary transmission. You are starving the superbugs of new hosts.
It is essentially moving the front line of medical defense away from the heavy emergency room doors and pushing it out to the end of your street.
And this methodology aligns perfectly with another academic paper included in our sources on decentralization in healthcare. That paper argues that transferring the responsibility and the tools for public health interventions directly to the local, subnational level dramatically increases accountability, speed, and efficiency.
Right.
The Prima kiosk is the ultimate physical manifestation of that theory. It completely bypasses the delays of the WHO in Geneva. It takes the power of epidemiological surveillance and immediate triage and puts it directly into the hands of the community itself.
But implementing millions of these high-tech kiosks globally isn't just a technological challenge. I mean, it requires a massive economic restructuring, which brings us to a really fascinating part of the deep dive. We need to look at economics, empowerment, and the philosophy of love.
It definitely sounds like a strange pivot to suddenly discuss the concept of love in the context of an AI medical kiosk, computational epidemiology, and antimicrobial resistance.
It does.
But the sources are very explicit about the philosophical foundation that dictates how this project operates.
They are. The sources heavily reference a document called Charity, according to Germa. They explain that in the ancient Sanskrit language, the word prima translates to love. But the text is incredibly careful to clarify this. We are not talking about love in the sentimental, romantic, or emotional sense.
No, absolutely not. As Dr. Srivatsa defines it in these texts, love is an operational active service, and specifically, it is an empowering service. In this framework, Prima is described as the absolute antithesis of charity.
I found this argument so compelling. Charity, according to this philosophy, often conquers free will. It creates a dynamic of dependence. If a massive Western NGO drops a crate of free medicine into a village, the village is temporarily saved, but they remain entirely dependent on that NGO returning for the next dose. They have no agency.
The text argues that true love, in the prima sense, requires giving people the tools to diagnose themselves, to understand their own bodies, and to protect their own families. It is about setting them free from the monopoly of centralized expertise. The text actually states, if I truly love you in the prima sense, my goal is to make you strong, independent, and free. I am actively working to make you independent of me.
It's a powerful framework, and it isn't just theoretical. It dictates the entire economic model of how these kiosks are actually deployed on the ground. They are not just dropped into villages as charitable gifts that will eventually break and rust. They are designed from the ground up to be self-sustaining micro-businesses.
Let's look closely at the numbers from the provided business plan. A single Prima kiosk costs approximately 20,000 rupees to manufacture and deploy.
Okay, so that is roughly $250 or about 50 pounds in the UK.
In terms of medical infrastructure, that is an unbelievably low capital cost. You can build 1,000 kiosks for the price of one MRI machine. But the revolutionary part is who owns and operates it. The proposal explicitly states that these kiosks are to be operated by local individuals from within the community. Poor mothers, street vendors, marginalized women, local chemists.
They essentially become healthcare franchise owners.
Yes.
They receive basic training to maintain the physical kiosk, ensure the solar panels are clean, and assist elderly or nervous users, and they earn a direct income from it. They collect a small consultation fee for the use of the AI, a portion of which goes back to the Dr. Maya Foundation to maintain the software. But they also earn money through printing medical documents and displaying local advertisements on the kiosk screen when it isn't in use.
The financial projections for these operators are staggering, especially in developing economies. The business plan calculates that a kiosk operator in India could realistically earn 30,000 to 50,000 rupees a month. An operator in a low-income area in the UK could earn 15 to 20 pounds an hour.
So by turning the diagnostic kiosk into a profitable business, you create a massive vested interest at the grassroots level. The operator, the local mother or the street vendor, actively wants their neighbors to use the kiosk because it generates vital income for their own family. It transforms public health. It changes it from a top-down, often ignored mandate issued by a distant government into a highly motivated, profitable community service.
And the macroeconomic impact of deploying this micro-business model globally is what makes it a viable, necessary solution for national governments facing bankruptcy from AMR. The business plan projects that widespread deployment of the Dr. Maya Calm system will result in 40% fewer unnecessary hospital visits and diagnostic tests.
Wow.
It projects a massive 50% reduction in the global use of antibiotics, primarily because people will no longer be panic treating viral infections with broad-spectrum antibacterial drugs.
The ultimate metric, though, the one that prevents the 2030 nightmare scenario, is the reduction in the spread of antimicrobial resistance itself. The models predict a 36% decrease in the spread of AMR, which would generate an estimated $500 billion in global healthcare savings by preventing massive ICU admissions and long-term disability.
The math is undeniable. The savings are astronomical. But it still requires an initial injection of capital to manufacture the first wave of kiosks. The sources don't just rely on wishful thinking here. They suggest a multi-pronged approach for this initial funding, pointing to existing, successful models detailed in the WHO's own historical costing and budgeting tools.
Right. If a government asks, how do we pay for the first 100,000 kiosks? The sources point to historical precedents of creative public funding. They mention Costa Rica, which successfully used revenue generated from national lotteries to completely fund extensive immunization programs.
That's brilliant.
And they point to the city of Wonju in the Republic of Korea, which funded its entire comprehensive Healthy City project by simply earmarking the revenues from a local tobacco consumption tax.
They also heavily reference Finland's CAST program. This was a national initiative that allocated millions of euros to local municipalities, specifically on the condition that those local governments deliver intersectoral health promotion.
So the blueprint is there.
The blueprint for funding decentralized health exists. Local governments, corporate social responsibility, or CSR funds from major corporations, private philanthropists, and earmarked sin taxes on alcohol or tobacco can easily cover the $250 cost of a single kiosk. The return on investment, both in human lives saved from untreatable superbugs and in massive hospital costs avoided, pays back that initial $250 investment in a matter of days.
We have covered an immense amount of ground today. We started by looking at the fatal structural flaws of our current centralized public health system. We examined how forcing sick, highly symptomatic people to travel across cities to hospitals creates the perfect conditions for secondary infections and the rapid spread of superbugs.
We examine this staggering financial drain of ineffective, top-down propaganda campaigns that completely miss the mark because they fail to communicate with the illiterate and marginalized populations who are actually the most at risk during an outbreak.
Right.
We face the terrifying, scientifically documented reality of the looming AMR crisis. The post-antibiotic era, where a simple scratch, a minor fungal infection, or a routine surgery could be a definitive death sentence because we have completely exhausted our pharmaceutical options.
And finally, we explored the incredibly hopeful yet entirely disruptive solution proposed in these sources, the Prima kiosk. A rugged, solar-powered, AI-driven terminal sitting on your local street corner, capable of translating complex medical triage into a simple, color-coded screen.
Yes.
It empowers local individuals to run it as a micro-business, providing them with financial independence while simultaneously catching and quarantining the next pandemic before it ever reaches the hospital doors.
It demands a complete philosophical reimagining of what healthcare infrastructure should look like in the 21st century.
So, as we wrap up this deep dive, I want to ask you, the listener, to think about your own community. Think about your own daily routine, your neighborhood, your local shops. How would your interactions with the medical system change if, instead of waiting weeks for a 10-minute appointment with an exhausted GP, or sitting for 6 hours in a crowded, coughing hospital waiting room, there was a Dr. Maya kiosk at the end of your street? A familiar, trusted, highly intelligent system acting as the first gatekeeper for your family's health.
It leaves us with a final, rather profound question to consider, one that synthesizes everything we have discussed and debated today. We have spent the last century and trillions of dollars building massive centralized cathedrals of medicine, gleaming high-tech hospitals filled with million-dollar machines protected by layers of complex administration and bureaucracy. But what if the survival of our species in the post-antibiotic era relies entirely on dismantling that monopoly?
Huh.
What if our only hope against the superbugs is to take the power of diagnosis out of the centralized cathedral and place it directly into the hands of a local street vendor with a solar-powered screen?
Because if the year 2030 arrives exactly as the math predicts, and those massive hospitals are no longer safe havens, but rather the very epicenters of untreatable infections, that small solar-powered kiosk on the street corner might just be the only true sanctuary we have left. Thank you for joining us on this deep dive. Until next time, stay curious and take care of yourselves.